Good evening, everyone. On behalf of the Emirate Society, it's my pleasure. I'm Dr. Osama Giledi from Moorfield Eye Hospital, Dubai. It's my pleasure to start our webinar today on dry eye dilemma, clinical dilemma. And it's a pleasure to have two distinguished speakers today joining us, Dr. David Gritz and Dr. Mark Minner. And also, for the first time, we're going to have a real story from one of our patients to tell us how dry eye affecting her and how she cope with it and how she managed with it. And thank you for our attendance to join us in this Saturday evening. And first speaker for today will be Dr. David Gritz, who is a consultant ophthalmologist at the Cleveland Eye Hospital in Abu Dhabi. He's a corneal and refractive consultant. He had before he came to Abu Dhabi, he was in working as John Hopkins in America, and also had the experience in Saudi Arabia where he worked in a clinic. So he will talk us about dry eye in our region. As you know, our region is we had more dry eye in our area. So he will give more depth in this subject. And it's a pleasure to Dr. David to join us now.
I've been at the Cleveland Clinic now for a year, but I've had 3 years experience at the King Khalid Eye Specialist Hospital, as well as working other places. And my Master's of Public Health is actually in epidemiology, so this is going to be more focusing on epidemiology and the background, what contributes to our patients' problems here in the region, as well as in other places in the world that are similar. So dry eye syndrome is a multifactorial disease of both the tears and the ocular surface. As you all probably know, there's evaporative causes whenever there's lid disease and issues with the oil layer, and then there's also problems with the decreased production. But there's also contributions of other factors as well. And certainly in this region, and depending on the climate and other factors we'll be just discussing, that can have a huge impact on patients and the prevalence of dry eye. Now, this slide shows different countries where a prevalence of dry eye has been reported. The problem is that the definition that they used to say whether a patient had dry eye or not varied a lot between these different studies. But I think there is some reasonable information here, good information that in the United States the prevalence is relatively low. Whenever you get to more dry places like Saudi Arabia, the incidence definitely goes higher, and that study actually did have a fairly robust definition of dry eye, so 32.1% in Saudi Arabia. In Ghana, in university students who are studying a lot, there was a very high prevalence as well. And in Jordan, in the West Bank and Palestine, they found even higher rates of dry eye, which would make sense given the environment there. So this just shows a map with the annual rainfall of the Middle East region. And I think the amount of rainfall, the humidity or the lack thereof, does make a big difference in how much problems patients have with dryness. As far as the climate and the atmosphere, air pollution can contribute. One study did show that particularly sulfur dioxide had the most impact on patients' symptoms. Any sort of particulates in the air, low humidity definitely causes, and this has been shown in studies, causes worse problems with evaporation of the tears and more problems. Sunlight duration has been shown to increase problems with dry eye. And as you probably know, our patients talk about smoke, perfumes, any sort of volatile vapors definitely cause more problems with their dryness. Wind and other things that, again, contribute to the evaporation of the tears will make things worse. So indoors, so here in Abu Dhabi, at least 85% of our patients, at least in my practice, come in with dry eye problems. Very, very common. Almost everybody has some sort of dry eye problems. And the question is, well, why would that be? Well, I think the heat is intense, especially during the summer, but also people aren't out in the heat so much. They're in air conditioning, where there is this internal wind from the air conditioning. The air conditioning air is very dry. And the same thing can happen in colder climates where you're dealing with forced air heating or things that dries out the air, as well as the drafts and other air movement inside causes problems. I'm sure you've also heard your patients talk about how if they're in the car and the air conditioning vents are blowing on them, their dryness is much worse. Same thing in work situations. If they're somewhere that there is a breeze across their workspace, they're going to have much more problems. And these are things also discussed with patients. How can they become aware of these environmental conditions and then make efforts to adjust them and to create a better environment for themselves so that they'll have less problems with their dryness. But that study in Ghana and the university students did show that air-conditioned rooms were particularly associated with more problems with dryness. Study in Jordan showed that working with computers and contact lens wear played a role. The study in Singapore also showed almost 3 times higher risk of dryness for contact lens wearers. And there's a study at Johns Hopkins that showed that reading for 30 minutes silently affected both symptoms and the findings of both patients with dry eyes and controls. But these changes were much greater in dry eye patients. The anatomy of the eye. So whenever you're looking at examining patients, look at the things besides just the ocular surface, and particularly about certain details of the ocular surface. The study in Indonesia saw that tritium plays a significant role, and as we know from our clinical experience, both tritium and pinguecula play a role. Sorry for the misspelling. Anything that causes a irregularity or a raised area on the ocular surface is going to, the tears are going to fall off of it more easily, they're going to dry out more easily, and it's very common that you'll see on top of trigea or pinguecula or corneal lesions that there may be a clump of punctate erosions right over that lesion. Conjunctival chalasis is something that sometimes people will miss in their exam, but it's very important to look for. One study showed particularly nasal conjunctival chalasis was the worst at causing problems with dryness. It would look at the patient from, when they're sitting in their chair. Do you see scleral show? Because certainly the larger the palpebral fissure is open, the more likely they are to be having dryness. Corneal irregularities, scars, raised scars. Particularly the thing that I see most commonly is patients will have Salzmann's nodular changes, nodular degeneration. And on top of that nodule will be punctate erosions, or sometimes even there will be a small epithelial defect because of how dried out it gets. Salzmann's nodules not only look like the classic nodule, but they can have these kind of larger areas of geographic elevation. So looking very carefully, seeing if you see this, raised, elevated, grayish opacity anterior to Bowman's membrane. Whenever you put fluorescein on, it's going to show up as what's called negative staining, although it's not staining at all. It's just a lack of the fluorescein gathering on this area that's raised, just like the tears. That's why you have the dryness problem over these areas. And certainly, this is one of the most common indications I have in my practice for taking out Salzmann's nodules. With Salzmann's nodules out in the periphery, but it's not causing any problems, great. It can stay there, or the patient can just lubricate. If it's in the visual axis and affecting the vision, that's a good reason to take it off. But also, many patients, my dry eye patients, will have specifically ocular surface damage over the area of the Salzmann's nodule. By removing that nodule, patient is relieved of their symptoms, and it makes a big difference. Salzmann's nodules, I usually, personally, I just peel off the nodule, leave it that way. They can recur, which is something I always mention to the patient as a risk. If they recur, you could try to use mitomycin. I don't use mitomycin primarily because the recurrences typically are not as bad and don't happen so often that I feel that every case requires mitomycin. Ptosis can contribute, although it doesn't quite make sense. And certainly when a patient has ptosis and then they have the ptosis raised, that's really where the problem comes in. So it's common that patients will come in and they say, I noticed one of my eyes is drooping a little bit. And almost invariably, they will have less ocular surface damage, dry changes in that eye where there's a little ptosis. And I always warn them, I'll be happy to send you to the oculoplastic specialist, but if they raise this, your dryness problem is going to be worse. And the same with post-blepharoplasty patients. Once you raise the lids, I've had patients where they were asymptomatic prior to blepharoplasty, and after blepharoplasty, they had horrible dry symptoms that were very difficult to control. Systemic diseases are often associated with dryness as well. The Singapore study showed about 2.6 times greater risk in patients with thyroid disease. Autoimmune diseases such as primary Sjogren's, that's the basic definition of Sjogren's is dry eye and dry mouth. But you can also have secondary Sjogren's from a number of other systemic diseases. Lupus, rheumatoid arthritis, patients with scleroderma, those are very common reasons. Infiltrative diseases such as sarcoidosis, common to see dry eyes because the sarcoid will affect the lacrimal glands and decrease the amount of tear production. Amyloidosis, lymphoma is one possible infiltrative disease that can contribute. Hemochromatosis, infectious diseases, HIV, very common that patients with HIV, even whenever they are on antiviral therapy, we found in San Francisco that there was actually a higher rate of dryness in patients who are HIV positive. At that time, whenever we did that study, we didn't have viral counts were not part of the standard evaluation of patients, and so I can't make comments about the viral load role in that particular problem. Neuropathic disease, cranial nerve 5 palsies, facial palsies, Bell's palsy, all those things contribute to dryness. And then skin diseases such as acne, rosacea, and blepharitis, the whole spectrum of blepharitis contributes to dry eye issues. Smoking, another place where smoking affects everything. It affects our health in so many ways, and both the Indonesian and the Singapore study and the Saudi Arabia study showed increased risk of dry eye problems in smokers. A very interesting study in Egypt showed that passive smoking also played a role in dry for children. So it makes sense, makes complete sense. I'm sure that other secondary smokers in the household also would have worse problems, not just the children. Depression. Now, it's very interesting that there is a connection with depression and dry eyes. And I think this is probably a multifactorial issue. Some antidepressants can result in more problems with dry eyes, but there is the other issue of having a chronic irritation, chronic disease that can actually contribute. In fact, one study looking at quality of life showed that dry eye problems were equivalent in many patients to severe angina in other patients as far as the impact on the quality of life. So in your dry eye patients, that's another thing to be aware of. Do they seem like they're depressed? Are you feeling depressed whenever you're talking to them? And it's something to address and ask them about, because that can certainly, and then refer them for help with their depression, because it can make a huge impact on their lives overall. We're not just treating eyeballs, we're treating humans, we're treating our patients overall. So lifestyle and occupational factors can also play a role. There have been studies that show that urban populations are more likely to have dry eye disease, and as well as people with higher income. A study in Mexico showed that office workers were more likely to be affected by construction than construction workers. But I think it's a multifactorial thing we're talking about here. I mean, urban populations versus rural populations, there's different environments, different, there's so many different factors, but I think it's just one thing to keep in mind as far as what's been shown to be associated. Medications. Always good to look at medications and see if that can be playing a role as well. Antihypertensive medicines, particularly the diuretics can play a role. Antihistamines and decongestants can play a role. Anticholinergics, hormone therapies, even like birth control pills, can play a role in some patients. Antidepressants, you have to be whoever is going to be treating that patient's depression needs to also be aware of if that medication has a high rate of dryness or if it causes worsening of the dryness. Pain relievers, as well as dermatologic agents, isoretinoin, definitely can affect the oil glands and affect the tear health and evaporation. So takeaway points. There is a very high burden of dry eye disease across this entire region. It's related to environmental causes, but there are also multiple other causes that are contributing to this, as far as just the lifestyle, presence of air conditioning, the diseases we see, so it's just something to be aware of in all your patients and consider about how you can best treat that individual patient and help them the most. Thank you.
For the presentation and give us more insight in our region. For the attendee, if you don't mind, that if you have any question, just you can write it down in the box for the question. I'll ask Dr. David about his experience comparing Saudi Arabia and here, and also America. It's Saudi Arabia and Emirates. Do you feel any different between them?
One thing I've been impressed with here in Abu Dhabi, and I'm curious about your experience in Dubai, is that the level of symptoms is much more out of proportion to the clinical findings of punctate erosions and staining than in other places where I've worked. And I assume it has something to do with the evaporative causes that are common here, but it's a very curious finding that I didn't expect, and I see it every day. And I'm curious to see what your experience in Dubai is as well.
Yeah, it's the same, I think. Yeah, it's mainly evaporative. It's a lot of pulmonary gland dysfunction here than aqueous deficiency alone, I think, but the majority is a mixed. The other things about the smoking, by the way, is that shisha, I think, is much more harm than the normal smoking.
It's interesting. I haven't noticed that.
Because I think the environment of shisha is all more than normal smoking. I think, I'm not sure, but I think it's dairy or coffee with shisha. It's really much passive smoking. Everyone is almost the same level, smoker and non-smoker in that place.
Yeah.
I think here one thing I noticed about Accutane. Any experience with Accutane? I think it's very common. I found a lot of patients using it, and really is very, very harmful to the eye.
Absolutely. That's very common. I totally agree. And that's also, when it comes to refractive surgery, we're very careful that patients are off through Accutane for at least 6 months before we'll consider any surgery, because dryness can be so severe with the Accutane.
That's good. I didn't see any question for you yet, so it seems to be everything reasonably clear, but I think I'm sure maybe we'll catch you to more discussion about later with joint discussion. So the next things we'll have our real patient, Dr. Sara. She's a pharmacist, and really she will going to tell us about her experience and her history and her dry eye symptom, how much affecting her, how she could manage to cope with the dry eye, and we're going to hear from her real story about the dry eye and how things affecting our patient. And that's the first time we had real patient involved in our webinars, and looking forward for this interview with our patient, really.
Hi, Dr. Osama.
Hi, good evening. Sorry to bring you late, and thank you very much for participation and to share your experience and your thought, and I'm sure we'll learn from you.
Yeah, thank you very much. I'm happy to be with you today to share my story. And regarding my story, I don't know if it's a classic story you see every day or not, but I started in 2016 with my LASIK, and I did LASIK, and after LASIK, I discovered that I had mixed astigmatism. This mixed astigmatism led me to go further for the second step, which is the phakic ICL, because I had so much troubles in my left eye sight. Then after the problem of the sight was really solved with the phakic ICL, after the operation was like 8 months, I started feeling something like foreign body sensation in my eyes, terribly in my left eye. My right eye is okay, but my left eye is full of not normal sensation. My eyelid dropped, and I felt like I cannot open in the sunscreen, and this all investigations that you know. Then I tried asking what is it, and actually I spent like 6 months to know that it's a dry eye and that I have something related to the corneal surface. After that, I started all the kind of treatments that you can say or that you can recommend for me. I used long-term medications like cyclosporins, and I used also dry eye medications, and my dry eye condition never developed. I'm still walking with my dry eye medication. I'm still scared if I forget my dry eye medication at home, what I will do. I can take a day off just if I left my dry eye medication at home. Sometimes with humidity and ACs and all this, I can even use the dry eye medication 10 or 12 times a day, and that's really not good for my lifestyle. For wearing makeup, it's horrible. I cannot even wear makeup for like 3 years. For me, I hate having one eye open and one eye closed. Also the complications were not good because I experienced also some kind of the bandage contact lens, and this bandage contact lens led me to have abscess because I don't know, maybe because I slept with it or it was not the proper treatment for me, I don't know, but I got abscess, and thanks God it was not in the center of the vision. So I stopped everything. I stopped all hopes, and I started to live with it. I started to feel like it's okay. I'm like an asthmatic patient who use his ventilator or use his inhaler every now and then. But actually, part of me is asking if there is any clue. Is my eye going to open again? And do I feel more comfortable? Lately, also, I discovered that this eyelid problem or the drop in my eyes is like my meibomial gland problem. This also was told to me by many of the ophthalmologists I visit. So some suggests for me some medications for the meibomial gland dysfunction that I have, and I believe that I have this kind of complications. So now I have a dry eye, the severe dry eye, and also the meibomial gland dysfunction problem, like a complex of dry eye and surface area, ocular surface diseases. So I'm seeking now some help. Maybe I can find some suggestions with you. Maybe you can adopt this case, till I am treated, till my blepharitis goes and my eyes is open widely and I have this kind of juicy eyes like I used to have before. this is all my story, and I welcome any question about my case. Thank you very much.
That's a pleasure. I understand that's basically from your understanding, like 4 years ago, you had the LASIK. Initially, it wasn't too much draw after LASIK, and after after a year, that started to be bothering you more. Is that correct?
After the phakic ICL, not after.
So a year and something.
Yes.
And about the meibomian gland dysfunction, I must discuss with you that you did the warm compressor for very short. Is it and you didn't feel well? Is it difficult to the time and other things, or how is to convince you to do longer warm compressor? What do you think was the trick to convince patient? For me, I think meibomian gland dysfunction warm compressor is a very important way. But how for you? Why you didn't committed to it? Is it the difficult timing? Is it you didn't feel well initially, so you stopping, or what is
because the thing is, I made it for like 1 week in the middle of desperate medications. You know, you can tell I'm a desperate patient. I already gave up hope about it. So when I use a medication, when I don't find a difference, like in a week or something, I just leave it. So what happened with me, yes, I gave up hope. I used the warm compress for 1 week, and I got some thoughts like they tell don't press too much because this will affect the optic nerve and all this stuff. So I'm not experienced that much in doing this like meibomial squeezing and all this stuff. I'm not an expert in it, so I left it. That's why.
I understand from you also you had plasma drops and now using artificial tear oil. Is that correct? Just supplements now. You don't take anything else.
No.
Dr. Mark and Dr. David with us. Maybe you can join us.
Yeah, I would love to. Dr. Isra, let me ask you some questions. You were on cyclosporin in the past, right?
Yes.
You how long were you on it for?
Like 9 months.
Okay. And did you get any improvement at all?
No.
Was it 0 or was it just like not enough? Did you get 10%, 20% improvement? Was it just not significant? Did you get some help?
No, it was worse actually, because I felt like it increased the inflammation.
Okay. And then did you ever have plugs put in?
I had plugs, but for my meibomial gland problems, I needed to remove the plugs. And actually, after I removed the plugs, I become better.
Okay. And then did you ever have, going back to the cyclosporin, was it, when you said you felt worse, was that immediately after you put it in, or like did it burn?
It's not like that. It's not like it burns or not. It's like I feel my case is worsened when I use it. When I use it, especially for a long time, like for 1 month or something, I start feeling like my dry eye is a little bit more. That's why I didn't like it at all. I gave it 2 chances in my whole story, but I didn't like the results.
What other treatments for the blepharitis did you do for the meibomian gland? Did you do any other treatments besides warm compresses?
I did azithromycin, like azithromycin treatment. It was topical. Yeah. It made me better, but in a very short term. Like I was better for 1 week.
And then I don't want to hog all the questions, but did the serum tears help?
Which one?
The serum tears, the plasma tears.
Yes. The serum tears were better actually for my ocular surface. Like I felt I need little lubricants.
Okay.
But that was expensive.
Right. Yeah, they are expensive. And then the last question, and then I'll yield to David if he has any questions. Do you have any asthma, eczema, or family history of asthma or eczema?
No.
Okay.
Dr. David, do you have any question?
Yeah, so I just want to understand, the past 2 weeks, what has been your daily habits as far as what you've been doing to help yourself with this problem?
For my dry eye?
Mm-hmm.
For my dry eye, I use 2 medications now. I use Tialol Dew, and I like it too much.
What? I'm sorry?
Which one?
Tialol Dew. I don't know if you know it, but it's.
I lost you.
Tialol Dew. It's like hyaluronic.
Hyaluronic acid with tractose.
Yes. This one I use.
It's over the counter.
Yeah, this one I like it too much. It made my eye fresh. That's why I use it. Sorry?
How many times a day are you using that one?
For today, till now, I used it like 6 times.
Is that a typical number of times?
No, I use more. But those days, I feel that I'm better, little bit. So I use it like 6 times, like 10 times a day.
Does the number of times you're using it, is that based on symptoms, or is that just setting your cell phone and using it very consistently?
The symptoms, of course.
The symptoms, okay.
Sometimes I cannot even, in my harsh journey, this one, it came some days, I use it every minute. Every single minute, I use a dry eye medication. And I don't want to remember those days. But actually, it came like 2-3 months, especially the summer month, when humidity is too much. I use it like every half an hour, every 15 minutes. So it's altering my life too much.
Mm-hmm. And you said there were 2 medicines right now. What's the other one?
Yeah, the other one is like Ectoin. I don't know if you know about something like that, but it's Ectoin. Like,
okay.
The medication is not with me now.
Company.
Another over-the-counter drug?
Sorry?
It's another over-the-counter artificial tear?
It's a kind of some natural bacterial derivative or something that will return water, but it helps me actually. I like it too much, and I can use it as much as I want.
You have no symptoms in the right eye?
I have some symptoms, but here is the biggest loop. So I don't know if I treat my left eye, will I see something in my right eye or not? I don't know. But basically, I don't have too much symptoms in my right eye. My left eye is the affected one, not the right one, maybe.
When you went to the doctor last time and he or she put numbing drops in the eye, did it relieve the pain, or did you still have the pain?
No, it relieved all the pain, and I felt like I'm okay.
Okay, so the anesthetic.
Like I felt like I don't have any problems anymore. Only for 10 minutes.
So
I have one more question. You said that the plugs made you worse. Can you describe a little more detail about what exactly the plugs did, or what you felt?
I did plug my lower lid first, and after that, some suggestions were for the upper lid as well. But actually, when I put on the upper lid, it scratched my cornea. So I removed it, and I spent like 1 month healing my cornea. And after that, when I discovered that I might have meibomial gland problems, so most of the doctors advised me to remove it so that the discharges can be gone. So I removed it, and I didn't feel any difference. Actually, when it was in, I didn't feel that I used less medication or something. It was the same. So when I remove it, it's much better. I feel like my eye is more fresh.
We had a comment from the attendee, Dr. Graham, about the puncture plug, that when it's acute phase, when it's too much inflamed eye, puncture plug can exaggerate the symptoms, especially with MGD. But once it's settled, I think it will be helpful.
So So here, if there are no more questions, I can give you some of my thoughts. So the way I approach my dry eye, and this is the lecture I'm going to give to the attendees, is there's a lot of different algorithms to treat dry eye. And so what I try to do is separate dry into 4 categories. And if we can separate you into 4 categories, and you may have 1, 2, 3, or all 4 of the categories, then we can have a much more pointed, directed treatment toward getting you better. So the first category is tear deficiency or aqueous deficiency. That means that your eyes are not making enough tears. And so one of the things that I would do is, if you haven't had a Schirmer's test, is make sure that we do that and do Rose-Bengal staining to see if you have the classic staining pattern for keratitis sicca, which is dry eye. The second category is evaporative based on goblet cell deficiency. It's a small category, but this way, if we checked you and we saw that your tears were evaporating quickly, that would be a different treatment as well. The third category is blepharitis or meibomian gland disease, and that's its own category because it really is a very big category. And you can have blepharitis and not be evaporative. And then the fourth category is exposure, which means you're dry because you're not closing all the way. So have you ever had any lid surgery in the past? Cosmetic lid surgery?
No.
Yeah, okay. So it doesn't sound to me like you have the third problem, but you may have the first 3. The fifth category is what I call the co-conspirators. Those are the diseases that sound like dry but are not. So when a patient comes in, is sitting in my chair, and no matter what we do, we're not getting them better, I start thinking about some of these other diseases. And that's why I asked you about asthma or eczema, because allergies or atopic can make you feel bad as well. And then also neuropathic pain. And that's why I asked you about the anesthetic, because sometimes after a LASIK or after multiple operations, you can get a little neuropathic pain, which means, or corneal neuralgia, which means you're feeling pain even though there's not much going on your surface. But you gave a very clear answer that when you were treated with anesthetic, the pain went away. That tells me it's all surface pain. So we do have to get more aggressive at treating the surface. So now that we know that some of those co-conspirators aren't there, I think we have to focus on the 4 categories. And so one of the reasons I like to start with cyclosporin is, in my hands, and I'll go through this in my lectures, 85% of the patients do well on cyclosporin, but there's 15% who do not. You may be one of the 15%. There's 2 other immunomodulating agents in the United States called Xiidra or lifitegrast, and there's also a different type of cyclosporin. So the first suggestion might be, if cyclosporin doesn't work, you may want to try another immunomodulating agent like lifitegrast or even tacrolimus to help with your dry eye. That's the first suggestion, because that's going to treat the first 3 categories. You need to reduce that inflammation. The second mistake that I think a lot of doctors make is they treat with one drug. They feel like all drugs are a panacea, but many patients, dry eye is like glaucoma. It often needs a multi-treatment disease. So oftentimes what we'll do is we'll treat it with with cyclosporin and topical azithromycin and plugs and maybe a topical steroid. And so I think you might need 3 or 4 different treatments. And so for you right off the bat, whether we would retry cyclosporin or whether you would go on tacrolimus or lifitegrast, let's say you went on lifitegrast or tacrolimus, you'd go on twice a day, plus I might give you a mild steroid in that eye to kind of quiet the eye down. And then once your eyes are better, then I might replug the lower plug again, or use a collagen plug, which will be below the surface, because the one that was sitting on the surface irritated your eye. So we just want to see if plugging that drain will help you. And then in addition, I get more aggressive at treating your meibomian gland disease. So if we add azithromycin and that wasn't enough, then you could do something like Lipoflow or IPL, or even do oral doxycycline. If you didn't want to do an oral medication, we compound a lot of medications like metronidazole, and I'll go through that in my talk as well. So the way I would approach you is I would kind of, you have to reduce the inflammation, so you need to be on the immunomodulating agent. Whether you try cyclosporin again in a different form, or whether you go the lifitegrast or tacrolimus route, I would do that. And then I would also add back the azithromycin, keep you on the serum tears, because both of those things help, and consider collagen plugs. I would start with that, as well as maybe a topical steroid just to get you through the acute phase. And then we can start getting off some of those medications once you feel better. And then the last point is, If at the end of the day, nothing is getting you better, one of the other things that works quite well is a scleral lens. You were wearing a bandage contact lens, which I'm not a big fan of because a bandage contact lens can lead to hypoxia and it can lead to ulcers that you talked about. But a scleral lens is actually a very good dry eye, and it's going to help your vision probably as well. So at the end of the day, if none of those other suggestions work, I'd consider a scleral lens for you in that left eye, maybe to help make you feel better. That's kind of how I'd approach it. And I would see you back every 4 to 6 weeks, and we would add to our treatment based on the 4 categories.
So which kind of plugs you told me to try?
So there are collagen plugs, which are dissolvable.
Collagen plugs, okay.
And they go below the surface. And if, let's say you put the collagen plug in and you say, my eyes feel so much better, and it was actually not the closure of the puncta that bothered you, but the plug itself that was irritating your eye, you could also do a cautery occlusion, or every 3 months you could have an extended plug placed. I know it's not ideal to go back every 3 months, but that's another possibility.
That's okay, yes. Okay, and regarding the cyclosporins, I should try another kind of cyclosporins.
You can try another kind, or again, you see, I'm usually when somebody comes into my office, and one of the things my talk is going to talk about is what I call the false failures with these drugs. Patients will often come in and say it doesn't work for me, but there's a lot of reasons why those are not true failures. And so in your case, I'd want to kind of get to the bottom of why it didn't work, because there are 15% who it doesn't work. So you may very well be one of those 15%. But it may just be that sometimes when you use cyclosporin and we don't do anything else, then you don't get enough of an improvement. You need cyclosporin and plugs, because what we like to do is we like to reduce the inflammation with the cyclosporin and then raise the level of those healthy tears with plugs. So that's why when Dr. Greit said, hey, did you get a plug first? How did you feel? Sometimes when you put a plug in and you have not, and Dr. Osama said this too, you put the plug in, you raise the level of those inflamed tears, they feel worse. So I'd want to do this in a stepwise fashion. And if you tried the cyclosporin again and it really bothered you, then you can try one of the others like tacrolimus or lifitegrast. I don't know if you have...
And also the eyelid drop is associated with that, or why I feel like that?
So in my opinion, sometimes, when your eye's very irritated, you can get a little ptosis or a little swelling or lowering of the lid. It's almost like a spasming of the lid. But that's the other thing I'd want to do is I'd want to put in rose bengal or lissamine green, because those vital dyes will help us find those co-conspirators. Maybe you have a little SLK, and this is not actually dryness, but you have another process that's causing inflammation, like superior limbic keratoconjunctivitis, or maybe you do have a little vernal, and that's irritating your eye and causing your eye to droop. So the advantage of using those vital dyes is it helps us find some of those other co-conspirators that we may be confused and thinking you have dry, but you actually have something else.
Okay, thank you.
Dr. David, any comment?
Yeah, I would just say, I often tell patients there's no one best treatment. There's no one best tier. It's finding the right recipe for you as an individual. And that really points to Mark's point about it's not just be one thing likely for you. It's finding the right recipe. So, thinking about how much problem I'm having, find some way to quantify it, whether it's 0 to 10 symptoms and so forth, and really kind of logging that, like say, okay, well, the topical steroids helped me 2 points to feel better. The cyclosporin helped 1 point. The plug that was properly placed and not causing rubbing on my eyeball, which is a problem right there in itself, and you shouldn't say, I wouldn't say that plugs are a failure. It was just that plug was not properly positioned, as Mark said also. But I think it's going to take something that it's going to be some sort of recipe for you as an individual. And from what you said also, I can tell that you get impatient quickly and you get frustrated quickly. And so again, it's working through how long are we going to do this to see a change? Just for instance, if you're just using the artificial tears when you have symptoms, that's only treating the symptoms, it's not getting your eye healthier. So we need to do things to, whether it's saying, I'm going to start taking the artificial tears every hour while I'm awake, and I'm going to set my cell phone, it's going to remind me. And I'm going to do that for the next 3 or 4 weeks, because it's going to take time for your eye to improve its health. And sticking with a plan, sticking with this kind of plan and doing things kind of one step at a time to figure out what's the right recipe for you as an individual, and how can we get you back on track. I agree with everything Mark said. He did a great job of going over things. But the only other thing that I haven't heard mentioned was Mark mentioned oral doxycycline. But actually, I found that oral azithromycin is more effective than the topical, not as likely to cause irritation. There was a nice little randomized clinical trial of Iran where they showed that Z-Pak, just 5 days of azithromycin, is as effective as daily doxycycline. And the effect lasts for several months. It's less likely to cause side effects, particularly for women, because often women will get a yeast infection, problems like that from everyday doxycycline. There is a low dose form of doxycycline that can be very helpful as well. So I think those are other things to consider trying as you figure out what's the best recipe for you as an individual that's going to help you get your life back on track. Another thing is, mindfulness. And mindfulness-based actions is an 8-week course that really has been shown to help patients with many different kinds of diseases in dealing with the things we can't fix with medicine or technology necessarily, and learning how to, live your life as fully as possible, even whenever your eyes aren't feeling so great.
And I think at the end of the day, I would not give up hope, because I think one of the things the doctor who takes care of you has to do is think outside the box. And so by that means, if like what David said, if you've tried these things, and I also agree, oral azithromycin works. We have Azacite in the US. It's a great, very well tolerated medication. But thinking outside the box, like compounding medications. I like to use compounded metronidazole, which is great for rosacea. I like to use compounded doxy drops for people. He's right. Doxy can cause yeast infections, but I make compounded doxy drop twice a day, which is great for meibomian gland disease. And then there's other compounded ideas like albumin, which works great for comfort. Vitamin A ointment, which you can get over the counter. Vitamin A is great for goblet cell replacement or deficiency. And Vitapos you can get on Amazon. And then thinking outside the box with topical hormones like medroxyprogesterone or DHEA, which is a topical androgen, or a testosterone 50-50 mix with progesterone. There's a lot of great things that also can be tried. So I would not give up hope. I would not assume that you're going to live this like this. At the end of the day, the scleral lens might be the last resort, but it usually works. But I think you need to continue to try, like David said, whatever recipe is going to work for you, you can find one. It should help you, but don't give up. And we can always give you more suggestions. We have a lot of tricks up our sleeve usually.
Yeah. I just mentioned a compounding thing. Insulin eye drops can help some patients also.
Which eye drops?
Insulin eye drops have helped some of my patients here. Let's see.
And where is it? Where can I find it?
It's something that's compounded, like Mark said. It's made by a specialty pharmacy. So, and the other thing I often talk to patients is about teamwork, and really working together as a team. And if I ask you to do something, and let's say I say, please use your drops every hour while awake, then when you come back, you say, I was able to do it, and this is how I felt. Or you say, it's just not possible for me, and I did it 6 times a day or 8 times a day or whatever, But really kind of working together in that way, because and I know it's hard to stay engaged and to not get discouraged whenever you have a chronic disease like this. Yeah. But that's what's going to move you in the right direction.
And
working together with somebody.
Other comment from the
figure out what that right combination of things is for you.
Yeah. Other comment about the Flaubellet syndrome, which is one eye patient, maybe can be a reason. But I think she need to have very good reassessment from start and take it step by step all the way, really. And you're welcome to come, and I'll see you when you have time, and we'll start to check all around and see where's the area missing, and then we'll proceed it with that, really. Any comment from you, Dr. Isra?
Thank you very much. I appreciate your time, and I will be in contact for sure, so you can guide me later in the journey.
Inshallah, inshallah. Thank you very much, and thank you very much for that. So we're going to the next session now. So basically, it will be Dr. Mark Milner. He's a associate professor from California. He's going to talk about how do we get good success in treating chronic dry eye disease. So I'm looking forward for his presentation. He's very well known in many of the webinar and activity, and he's very, very well known about dry eye disease and management. So we'll come to our webinar, and welcome you to present, give us a nice, as usual.
Thank you. I appreciate it. I've been in your region in person, and I've given several lectures, and I really wish I was doing this in person, because you have a very beautiful part of the world, and I love coming there. So unfortunately, COVID has had other plans for us, and so I have to do this virtually. But this lecture really follows nicely the case that you just saw, and my approach. What I'm going to try to do is give you a very practical approach to treating dry eye, because we know, as we can see from the case we just presented, that this is a very complex disease. It's not always easy to figure out what the cause is and what the treatment is. So I'm going to try to give you a very practical approach. I'm also, just on the tails of what we just witnessed, talk about what happens when you feel like you have failures, especially with right now the drug that you do have available in cyclosporin, what you can do to help with that. So again, I'm right now, I was in Connecticut for 25 years, affiliated with Yale. Now I'm the director of cornea at Goldman Eye in Florida. These are my disclosures, and there are several here that will have some relevance for what I'm going to be speaking about today. So I always start out the lecture by asking, how do we think about dry eye disease today, differently than we thought about it 20 years ago? And that, first and foremost, is that we know this is an inflammatory process. We used to have this misconception that Sjogren's patients were inflammatory, non-Sjogren's patients were not inflammatory. We now know that that's not true. Even if it's not clinically apparent, we know that there are T cells, and dry eye is a very T cell mediated response. We know that there are T cells and cytokines in the tear film, the conjunctiva, and the ocular surface of patients with dry eye disease. Even if the eye is white, there's inflammation. Second is that we now have treatments that go to the heart of the problem to reduce the inflammation. When I trained at Proctor, David and I both trained at Proctor. When I trained there a long time ago, we had nothing to treat dry eye. We just had things that palliated, like ointments and gels. So we used to have to compound cyclosporin. And you may not know this, but cyclosporin needs an oil emulsion, so we put it in peanut oil. And for people who couldn't tolerate peanut oil, we put it in cyclodextrin. So we had nothing, and we had to compound cyclosporin back then. But now we have treatments that go to the heart of the problem. The third way we know it's different is that we want to change your thinking about dry eye disease. This is not just a nuisance, but this is actually a chronic progressive disease that, if left untreated, these patients may actually get worse. And this is a new way of thinking. Patients will come in, and if you tell them they have high blood pressure, if you tell them they have high cholesterol, they expect to be on meds forever. Even if you tell them they have glaucoma, they expect to be on drops forever. But if you tell them they have dry eye disease, they will look at you and say, well, I'm not going to be on this for more than a month, am I? And the answer is yes, this is a chronic disease. And then last is that I think dysfunctional tear syndrome is a better definition, because it's not just about tear quantity, but tear quality as well. Meaning that you may have dry eye, but your tears may be inflamed, and that your problem is that you have a poor quality tear, not a poor quantity of tear, or you may have both. So I know that all of you know this. I'm really not going to dive into the pathophysiology much, but I want to show you one key slide to explain what happens. So on the surface of the cornea, there's some sort of stress, whether it's a desiccating stress or wind or smoke or pollution. That causes an upregulation of T cells and cytokines, and increase in ICAMs on the surface. And those T cells produce cytokines such as interleukin-6, tumor necrosis factor alpha, IL-1, MMP, such as matrix metalloproteinase 9. And those cytokines can damage the surface and trigger more inflammatory response. But in addition, the T cells will activate what's called antigen-presenting cells, or APCs. Those APCs actually travel they migrate through the lymphatics to the lymph nodes where they recruit more T helper cells. And those T helper cells will migrate back to the surface and get activated, and it triggers that response. So we know this is inflammatory, but what a lot of people will say, but what really is the predisposing factor? Is it hormonal? Is it age? Is it all autoimmune diseases? What's the cause? And David did a great job, Dr. Greitz did a great job showing all these different things that can lead to dry eye, and it's very it makes this complex. But it's not just aging. We know that as we get older, we get drier, but menopause is critical because androgens decrease. And androgens are critical to tear production and lacrimal gland secretion. And by the way, it's not just women that get decreased androgens. Men do as well, obviously. There's allergic responses. There's environmental stresses, such as contact lens wear. We know that patients who wear contacts and patients who have dry eye have very similar increases in their inflammatory response. So contact lens wearers will also see an increase in IL-6 and MMP9s, et cetera. Wind, pollution, low humidity, lack of sleep. We know that when we're on our computers and our iPads and our cell phones, our blink reflex decreases. Normally, we're blinking about 16 to 20 times a minute. But when we're looking at our iPads and our phones, it drops to 4 or 5 times a minute. So if you're borderline dry, you can exacerbate your dryness by looking at the computers. We know surgery such as LASIK and corneal transplants, especially because you become neurotrophic. And we know neurotrophic decreases your innervation to the lacrimal functional unit. It can cause dryness. And then there's medications, right? There's a lot of medications, systemic, such as antihypertensives, antidepressants, anticholinergics. Antihistamines are classic for causing dry eye. And we know topically preservatives are really notorious for exacerbating dry eye, as well as topical antihistamines, which can dry the eye out. And then lastly, there's systemic autoimmune triggers, like systemic autoimmunity such as lupus, rheumatoid arthritis, Sjogren's, graft versus host, etc. These can all cause an immune-mediated inflammation both in the lacrimal glands, on the conjunctiva, and in the tear film. And those inflammatory mediators can be expressed into the tears and onto the surface and really cause a dry eye. So this to me may be the most important, or I think the best slide to talk about this cycle of inflammation, this merry-go-round of triggers or things that can lead to dry eye and dysfunctional tear syndrome. And I include this in every single lecture I give, because what it shows is that there's so many different factors that can cause dry eye, but it is like a merry-go-round or a carousel where you can jump onto this carousel from any point. So let's look at this irritation of the eye, no matter what the cause is. Irritation causes an upregulation of T cells and cytokines that leads to inflammation. Inflammation, when you have inflammation of the lacrimal gland, meibomian glands, goblet cells, you have a tear film deficiency and instability. That causes more irritation, which leads to more inflammation, and the cycle continues, all ultimately leading to signs and symptoms of ocular surface disease. But the beauty about this slide, the beauty about this is that this is a carousel where you can jump onto it at any point. So what kind of things cause irritation? Well, we said smoking, pollution, contact lens wear, topical medications, surgery, that all causes irritation. Irritation leads to inflammation, which leads to tear instability. What kind of things jump onto the carousel from the inflammatory point? Rheumatoid arthritis, lupus, Sjogren's, graft versus host, etc. That causes inflammation. Inflammation leads to tear instability, which leads to irritation. What kind of things jump onto the carousel at the tear instability circle? Well, that is menopause. We said androgens are critical. Rosacea can lead to an unstable tear film, or even oral medications. But at the end of the day, it all comes down to inflammation, and it all comes down to signs and symptoms of ocular surface disease. So if we can decrease the inflammation, we can improve that function, we can normalize the tear film, decrease the surface inflammation, stimulate healing, and restore that neuronal feedback, and work the cycle in the opposite direction. So if you said to me, okay, Mark, listen, we want the bare bones minimum. We want to know what the bottom line treatment is to treating dry eye. And if you want me to simplify it, you do 3 things. And if you do these 3 things, you'll treat dry disease. And again, this is if we go back to our patient who had dry disease, if you do these 3 things, you usually can help. So one is treat the trigger if you can, meaning if you know the trigger, if it's contact lens wear, if it's, then decrease the contact lens wear. If it's rheumatoid arthritis, then send it to your rheumatologist and treat it systemically. If you know the treatment, if you know the trigger, treat it. Second, regardless of the trigger, you still have to treat the inflammation. And I think that's what we have to do in our patient that presented today, is that regardless of what's causing it, we still have to work that cycle in the opposite direction. So she still needs, whether we retry cyclosporin, whether we go to tacrolimus or lifitegrast, we still have to treat the underlying inflammation. And then the last is to treat it chronically. So if you do these 3 things, treat the trigger, treat the inflammation regardless of the trigger, and treat it chronically, because once you stop the medications, it's going to come back. You will have a happier, healthier patient. So how do we treat the inflammatory disease? Well, there's several things that we can use to treat the inflammatory disease. Steroids is one. We know steroids will reduce the inflammation. Steroids may not be a great long-term solution, especially if someone's phakic or if they're a steroid responder. There are some patients who I'll keep on a very low dose of Flarex or fluorometholone once or twice a day, but for the most part, it's not my favorite long-term treatment. There's cyclosporin, a phenomenal treatment for treating dry eye, because we know that we need to treat this disease chronically. We need to treat the inflammation, and this is a safe treatment that can be done forever. There's lifitegrast in the US, which also is a T-cell immunomodulator. They work slightly differently. Cyclosporin, we'll get to this in a second, but cyclosporin goes into the cell to basically form a complex with calcineurin, whereas lifitegrast is an LFA1 antagonist that works on the surface of the T-cell to prevent the T-cell from activating. And then there's omega-3 fatty acids, which are also anti-inflammatory. But at the end of the day, if we can treat the underlying inflammation, now we're on the road to reversing that cycle in the better direction. So if you understand that, you say, okay, well, how can I approach these patients that are so complex? And there are several guidelines, several algorithms out there that you can use. There's the Delphi approach, which was the ITF guidelines, the International Task Force, that was published in Cornea by Behrens in 2006. There's the DUES 1 and 2. The 2 came out in 17, and then there's our algorithm, our CEDARS DTS algorithm. This is my approach that I formed a panel with my CEDARS partners, and we basically came up with an algorithm that we published in 2017. Most of these algorithms are severity-based approach, and this is the problem I have with them. So if you take the ITF guidelines, that task force of 17 specialists that convened at Wilmer, what they did was they said, okay, let's take 4 levels of dry eye, mild to moderate, moderate to severe, severe, and extremely severe, based on conjunctival signs, corneal staining, and other signs, and then we can assign a treatment based on that. Well, this is a great start to the algorithms, but the reality of it is, and if we notice cyclosporin's at level 2, but it's really 2, 3, and 4, and if you notice, plugs are not to level 3. And what they said was, we recognize you need to reduce the inflammation first, and then raise the level of healthy tears with those plugs, which is exactly what we talked about with our patient. But again, the problem I have with this is that it's severity-based, meaning that you're going to treat mild blepharitis the same way you're treating mild aqueous deficiency. So that never made sense to me, but it is a great starting point. Well, DUES came out with their first report in 2007, and then in 2017, they came out with their second version of this. And I think this is the most comprehensive paper or series of papers written on dry eye disease. And I always say, if you want to learn dry eye disease, you put up a pot of coffee, you hunker down in your house, and you go through all of these papers, which are, by the way, over 400 pages. There are 150 clinical and basic science research experts worldwide that came together, took more than 2 years to complete, and the full report, as I mentioned, was 400 pages with 10 subcommittees. Each subcommittee had its own paper, and if you count the introduction, there were 11 papers involved in this complete report. And you can go through each report, and you'll have different topics like the definition, and then the pain and sensation, or the pathophysiology, or the management, or how to design a clinical trial. These are all in there. And these are all excellent papers to reference to. It gives you a great roadmap, and that you can start with the patient and look at whether they're asymptomatic or symptomatic. So if we took our patient today and we worked through, we could see that this is a nice approach on how to come up with a diagnosis, whether it's aqueous deficient or evaporative. We know most evaporative is blepharitis. And then on each report, we could go ahead and basically, you can see on the bottom, it says, okay, if you've gotten to this level, this is the management of dry, or this is how to diagnose it. And it can give you, each paper helps you in that section. And then ultimately, you start with triaging, and you work through this algorithm by looking at certain tests such as tear osmolarity, and you can get to a diagnosis. Is it evaporative? Is it aqueous deficient? Or is it a combination? Where we understand that at the end, it's usually combined. Most people have both. And this is a phenomenal roadmap or approach on how to do this. But at the end of the day, what we want to do is basically come up with an easy approach on how to treat these patients. And the DEWS tool, although it's excellent, to me is not as facile in the office. So yes, the goal is to restore homeostasis. It's an organizational tool. It separates aqueous versus evaporative or mixed. But at the end of the day, it's still treated based on severity. So let's talk about the different categories of treatment. So in my approach, what I decided to do was I decided to say, let's take a diagnostic approach first. Because I think if you can separate your patients into different diagnoses, I think you'll have a much more facile, much more directed treatment. And I think it's a better way, it's an easy way for you to approach this in your office. So Michael Lemp did a great slide where he looked at different types of aqueous versus evaporative. Aqueous you can separate into Sjogren's versus non-Sjogren's. Evaporative you can talk about intrinsic versus extrinsic. And at the end of the day, you can have these different categories. But to me, that still wasn't easy enough. So about 17 years ago or 16 years ago, I developed my own algorithm that separated patients into 4 categories. I mentioned it to you before when we had this would talk about her dry eye. And if you can separate, this was published in Current Opinion in Ophthalmology, January 2017. You can upload it. It's a free PDF that you can get, but it's a nice way to approach how to take care of these patients. And so what we do is we separate patients into 4 categories. One is aqueous deficiency. These are people who do have a decreased tear film. They actually have a low tear volume. They've turned down their faucet. Second is evaporative based on goblet cell and mucin deficiency. As I mentioned, a very small category, but let's not forget it, because there are people who get goblet cell deficiency that don't have blepharitis but are still evaporative. And if you don't check tear breakup time, you can miss that. And so who, for example, gets evaporative based on goblet cell? Well, anybody with conjunctival scarring, such as cicatricial conjunctivitis like pemphigoid, Stevens-Johnson syndrome, chemical injuries, toxic epidermal necrolysis, etc. These patients can get scarring. And if you see conjunctival scarring, assume you have goblet cell deficiency. There's blepharitis or meibomian gland dysfunction, and I separate it into its own category because I recognize that you can be evaporative and non-evaporative. So to just merely say it's evaporative based on blepharitis, what about the person that has an anterior blepharitis, that has an inflamed tear film but is not evaporative, yet they still have signs and symptoms of dry disease? The fourth is exposure. As David mentioned, if you have somebody who has a poor lag of thalamus or poor blink, they're going to feel dry. You can be the best cornea specialist in the world and treat the first 3 categories. But if you miss that patient that doesn't close all the way, they have a partial opening, especially nocturnal when they sleep, they're going to always feel dry. So if you can separate your patients into these 4 categories, you can get a much better approach. Now, the reality of it is as I mentioned, there's a 5th category, what I call the co-conspirators. These are the diseases that masquerade as dry or contribute to it, meaning that they're sitting in the chair, like our patient said, nothing's getting better. Start thinking about things like SLK, medicamentosis. Sometimes they're on 8 or 9 different medications. Tygasins is a classic co-conspirator because it sounds like dry, but it's not. Mucus fishing syndrome. They go into the eye and they dig out the mucus, and until they stop doing that, they will never feel better. Contact lens related toxicity, hairspray keratopathy or chemical toxicity, where they're standing in front of the mirror, spraying their hair, and they get a keratitis, allergy or atopic because the symptoms sound the same, but also they're on antihistamines. As David mentioned, conjunctival chalasis can dry the eyes up, but can be a great co-conspirator. As Dr. Osama mentioned when he made that comment, floppy lid syndrome, absolutely. And one thing not to forget is corneal neuralgia, right? Because corneal neuralgia, as I mentioned with our patient, if a patient says they have pain and it's out of proportion to findings, and you put anesthetic in and it does not relieve that pain, start thinking about a neuropathic pain. So if you can do your fluorescein staining like we talked about, the staining patterns can help you. So the top one on the left could be anything from severe dry to chemical. In the one below that could be blepharitis or exposure. 3 and 9 o'clock staining is classic for contact lens wear. This to the upper right could be, again, early dry eye versus chemical toxicity or UV toxicity. If this is the right eye, the second one on the right could be medicamentosa, because that's where the medicines are draining by the punctus, so they get a high concentration and irritation. And then the last one is SLK or foreign body or vernal, etc. The first three here are mild, moderate, and severe keratitis sicca, where you have rose Bengal staining in that interpalpebral fissure with filaments. That's classic for keratitis sicca. The one on the lower left could be mucus fishing syndrome or medicamentosa, and that's classic to see that rose Bengal staining. And then, as I mentioned, with our patient, it would be nice to do rose Bengal staining and see if they have superior uptake. Maybe she has SLK and doesn't know it. Maybe we're spinning our wheels. So if you can separate your patients into the 4 categories, remember, they're not mutually exclusive, that you may have 1, 2, or all 4 of these. Well, now we can have a much more directed treatment. So what do we do for our patients who have aqueous deficiency? Well, you can do things like replenish tears, such as artificial tears, ointments, ocular inserts, or nasal stimulation. There used to be True Tear, which is a stimulant that you put up your nose, and that can help by stimulating the nasociliary nerve, can cause you to reflexively tear. There's a company in the United States called Oyster Point that has an investigational nasal spray to stimulate the nasociliary nerve and cause a reflex, not a reflex tear, but a complete tear from lipid, mucin, and aqueous. You can actually preserve or conserve tears with plugs, surgery such as cautery occlusion, or moist chamber goggles, which are underutilized. And then you can change lifestyles such as moving and other things. But again, this might not be a practical solution. But at the end, anti-inflammatories such as steroids, cyclosporin, and lifitegrast must be used. And as I mentioned before, cyclosporin forms a complex with cyclophilin. It goes into the eye to basically prevent the T cell from flipping the switch on. It inhibits the activation of T cells, and it decreases the cytokine production and T cell migration. Lifitegrast works on the surface by preventing the binding of the T cell to the ICAM on the surface, so it can no longer activate. And if it can't activate, it can't migrate and release cytokines. So these work differently. In the US, we use cyclosporin and lifitegrast together a lot because they are synergistic. And so that's another option for our patient to maybe add cyclosporin and lifitegrast together. Other innovative treatments, which you heard me mention, topical hormones such as medroxyprogesterone or DHEA, which is an androgen, a 50-50 testosterone progesterone mix. These were all compounded. There's autologous serum, which she was on. Diclofenac is not available in the US. There's another dapsone, which is another immunosuppressive agent. I love using topical albumin, which works great because it's mucoadhesive and it makes people feel better in their dry eye. Scleral lenses. And one thing we didn't mention was amniotic membrane, which this patient maybe benefit. Putting a Procara in might help her a lot with her symptoms, especially because we know it regenerates nerves. And then lastly, nasal stimulation, which I mentioned. For goblet cell deficiency, let's take that category. What can we do for those? We talked about replenishing goblet cells. Cyclosporin is a great treatment. There are plenty of studies. Flukefelder, Allergan, and even Sanjay Rao did plenty of studies showing that cyclosporin increases goblet cell density by almost 200%. Lifitegrast also has studies that show that. And then we talked about vitamin A you can get that over the counter to help replenish goblet cells. There's moist chamber goggles, scleral lenses, another great treatment, and then environmental changes, as well as treating the lids. For blepharitis options, we know that for anterior, it's usually bacterial, so you can use, in addition to hot compresses and lid scrubs, there are also antibiotics such as erythromycin and azithromycin, as we mentioned. There's steroids because we know both anterior and posterior has an inflammatory response as well as a bacterial. Even in posterior, the bacteria produces lipases, which break up lipids into soaps and free fatty acids. Those soaps are irritating and the free fatty acids are pro-inflammatory. But at the end of the day, we know that cyclosporin works to treat posterior blepharitis because there are inflammatory cells in the meibomian glands just as there are on the lacrimal glands. So Eric Donenfeld and Hank Perry did a great study showing that these work just as well for posterior blepharitis as they do for aqueous deficiency. But at the end of the day, we know that we have to treat both the inflammatory and the bacterial component. Other innovative treatments, we talked about metronidazole, doxy drops. There's also clindamycin ointment, which our patient could think about doing, which is a great treatment compounded. And then there's flaxseed and omega-3. We know flaxseed thins the oily layer, and the omega-3 suppresses inflammation. We talked about pulse light therapy, LipiFlow, and meibomian gland probing. So how do we take our algorithm now? So at the end of the day, if we can separate our patients into these 4 categories, decreased Schirmer's, decreased tear lake, and rose-bangle staining, we know we have aqueous deficiency. If we have a rapid tear breakup time, conjunctival scarring, goblet cell deficiency, and remember, we're not checking goblet cells in the office. We're not doing biopsies and we're not doing impression cytology. So for me, the second category is a diagnosis of exclusion, meaning if they have scarring, they have a rapid tear breakup time, and they have minimal blepharitis, I know they must have goblet cell deficiency. Third category is blepharitis, based on anterior posterior blepharitis and lid erythema and debris. Fourth category is exposure, lag ophthalmos, partial blinking, and lid function. Well, now you can direct your treatment based on these categories. So if our patient comes in and she's 25% better on cyclosporin, well, now if she's still tear deficient, we're going to plug her. If she's 25% better and she still has blepharitis, we're going to add azithromycin. But we're going to direct our treatment based on those 4 categories. So why do we start with cyclosporin? And one of the things that I want to stress to you all is to start it early, right? A lot of times doctors will say, well, I start with cyclosporin late because it's really a big gun. That's not true. It's one of the safest medications out there. And you want to prevent the patient from getting to the point where they need 2, 3, or 4 different drugs. You have to break that cycle. So if you start cyclosporin early, you will end up breaking that cycle and preventing some of those long-term progressive problems.
To you, how long do you give azithromycin? Is it an oral or topical?
So I'll let David talk about the oral because I know he's used oral. I've used oral too, but we have a great topical azithromycin in our it's called Azicite, and I love it because of several reasons. One, we know azithromycin has great tissue penetration. It's very high concentrations in the skin, so you can put a drop in and it lasts for at least 2 weeks in the skin. Plus, we know that the macrolides like azithromycin and erythromycin have great anti-inflammatory effects. So it really helps the meibomian glands become more normal. So you're not just using it for the antibiotic effects, but the anti-inflammatory. And then lastly, it has great coverage for the ocular flora, especially gram-positive such as Staph aureus. So for me, I like to use topical azithromycin once a day for a month, and then I'll pulse it. I'll either use it the first week of every month or the first 2 weeks of every month for 6 months minimum to see if I can keep that meibomian gland under control. Sometimes patients will say they get breakthrough after a week off of it, so I'll have them use it every other week. But they get a month of azithromycin, and then I'll pulse it usually first 1 or 2 weeks of every month. David, what do you do for the oral? I give them the Z-Pack dosage, equivalent, and then see them back in a few weeks, through 2 or 3 weeks, usually 2 to 4 weeks, I'll say. Ask them how they're feeling. Reassure them that it's not just like you said, the tissue penetration, the persistence of it. It's going to stick around for a while, and they're going to get a benefit over time as well. So, and so that's why usually 3 or 4 weeks is more common that I ask them back, ask how they're feeling.
If they say I'm feeling better, great. I'm going to note that in the chart, and that's going to be one of my things I'll go back to when they relapse or when they get worse again. And usually single dose will last 2 or 3 months at least. Some patients it'll kind of kick them into a better level and they'll do better much longer. There are some patients who need it once a month, once every 2 months, kind of continued cycles. So I have a similar experience to your topical experience with the oral as well.
You know, when they first looked at azithromycin, I forget which company orally, the oral azithromycin, they were going to scrap it. They were going to say this doesn't work because they gave the patient azithromycin and then they measured blood levels and there were no blood levels. So they thought it was excreted immediately. And they said, this drug doesn't work. And we don't keep it in our body until they looked at tissue concentration. What they found was azithromycin goes into the tissues at such high concentration. It's not in your serum. And so that's why you can use oral or topical for, one dosing and it lasts for a long period of time.
Yeah, I just bought sometimes different patients. If someone is using a lot of medication topical, I use tablet. I don't want to add too many topical. So I use systemic really, and the other one who's uses topical. So sometimes I use this one, I use the other one.
Yeah. And the other thing that's key is children can get terrible blepharitis, and you don't want to give them doxycycline because it's not great for kids. Sometimes azithromycin might be a better treatment. Obviously dosing based on their size, but that's another option for you too.
And also for women.
That's a great point about children.
About pregnancy. Also, there's no risk of a problem with the pregnancy with azithromycin, not like doxycycline.
Yeah. David, what were you going to say?
Oh, you remind me of the severe blepharitis that kids can have, and I'd also comment that often in my experience it's extremely asymmetric.
Yeah.
And so people don't realize that that's the underlying issue. And
with that, to that point, cyclosporin is a great treatment for, I often give it to, because they get terrible blepharitis, cyclosporin is a great treatment because it's much safer than steroids, especially in kids. And you can use cyclosporin forever, even in a 10-year-old for the rest of their life. And it's going to help control that blepharitis, as well as Tigasins, another great treatment for Tigasins, which we use. We did that in Proctor a lot. We used to use cyclosporin for Tigasins.
Yeah.
Question to the Dr. Mark about, do you use any inflammatory marker to help you using cyclosporin or inflammation more or not?
Yeah, so I will tell you that we used to, a lot more than I do now. We used to use MMP9 or Inflammadry, which is a marker to see if there's inflammation. It's kind of like an assay. I don't know if you have it there, but you touch the fornix, and then you can see if one line means that you have the control, 2 lines mean that you have greater than 41 nanograms per ml of MMP9, which tells you that you're inflamed. And then there's also tear osmolarity. We know that tear osmolarity, anything under 300 is considered normal. 300 to 310 is mild, 310 to 320 is moderate, and 320 to and above is considered, 340 above is severe. Anything greater than 8 millimeters in each side or 8 points in each side is considered dry. So I'm not a big advocate of using the markers because for me, if you look at my algorithm, I know that they're inflamed. I want to direct my treatment based on the 4 categories, not so much on inflammation. Where I do use those markers, I like to use them is on those patients that are neuropathic. So if they come in and they say they have severe pain and they have severe dryness and the eyes look pretty good, the findings are the symptoms are out of proportion to the findings. Well, now if I do an MMP9 and I see that they're negative, it helps me confirm, in addition to the anesthetic test, that there may not be a truly ocular surface, but more of a neuropathic pain. That's why I like to use the MMP9. And then the other nice thing about these tests is, patients sometimes need validation to stay on their treatment. So if you do the tear osmolarity and they say, well, I was 340 last time, now I'm 310, you're getting better, stay on the treatment.
Yeah, it's a good part to educate the patient about their disease and they can feel there's a number which is getting better and that's building their confidence. I think patient education is very crucial, really. Any feedback about patient education, what you do for your patient, you give them a long time for the first visit to give it.
So I had a professor in med school, who used to say that 25% of what you lecture to the audience gets retained by the audience. The other 75% goes out the window when they walk out the door. He said, so I'm going to repeat the important things 4 times. So I know if he said it 4 times, it was on the test, okay? So if you think med students only retain 25%, how much do you think your patients retain? So from me, when they're anxious, they're sitting in the chair, they don't understand what you're saying, I like repetition. So education to me is one of the most important things to gain success, which is what that PERSIST study showed. So I go over it with them, especially my initial patients. Then I've typed a whole series of things on how to help them get benefit, on how to use the cyclosporin, that it may take a few weeks to work, that they can refrigerate it. And then my assistant goes through it with them again. And so now they've gotten it at least 3 times, if not 4. And I think that's critical because patient expectation is huge. If you don't explain to them, I guarantee you most of them are going to walk out, use it for 2 days and say it doesn't hurt. It doesn't help. So I think education is one of the most important things you can do for compliance and success.
About the cyclosporin, what's the shortest course you give, and the longest period you give cyclosporin so far for you?
So I'm going to start with the longest first. I tell all my patients to expect to be on it forever because, like I mentioned, dry is a chronic progressive disease. And so I want them to be on it, expect to be on it forever. Now, after a year, if I go a minimum of a year on cyclosporin, if after a year they say to me, well, listen, I'm doing great, I want to try stopping it, then I'll tell them they can stop it, but expect to go back on it. If they're one of those people who have more signs than symptoms, or if they have more symptoms than signs, they don't even have to call me. If they start getting symptoms, they'll restart the cyclosporin. But if they're one of those people that have more signs than symptoms, they may not know that they're getting recurrent keratitis. So I'll say, you can stop the cyclosporin, but I want to see you back in 2 or 3 months. And if you get keratitis again, we're putting you back on the cyclosporin. I've had patients go down to once a day or every other day of cyclosporin and still get success. Anything less than every other day does not work. As far as the shortest course, so for the most part, a lot of our patients are complex and really they need 6 months to a year minimum. However, I will tell you that I've had some young people who get EKC. And we know with EKC, you get pseudomembranes and scarring, and they can get a loss of goblet cells. So very often they'll tell me they feel dry, and I'll put them on cyclosporin twice a day. But because they're young, they usually can replenish their goblet cells. They can kind of repopulate as they heal. And so many times after a few months, they can get off the cyclosporin. Or I have patients who teeter on having dry eye, meaning that they are borderline dry and the seasons put them over the edge. So let's say in the winter when the humidity is really low, they'll go on cyclosporin for 3 to 4 months, and then they go off of it in the summer. Or I have people in the summer who have a mild vernal, and they say that the cyclosporin helps them because we know that vernal is both type 1 or IgE mediated and type 4 T cell mediated. So in the summer, they may go on cyclosporin when their vernal is bad because it helps both the dry eye and the vernal that they get. So I might, use it seasonally, but most patients are on for a while.
I'll also make a comment about cyclosporin use and Restasis use. Although it's recommended to use it twice a day, there are patients who I'll say, use it as much as you want or use it, many times a day, not necessarily because of the effect of the cyclosporin, but because of the effect of the vehicle. Whenever the FDA trials are going on, that's one of the reasons why they had such a hard time seeing the beneficial effect of the cyclosporin was because the vehicle is a very good dry eye treatment in itself, a very good artificial tear in itself. It used to be available called Endura, and I'm not sure why Allergan stopped making it, but I think it was a loss they did. But anyway, but I think that's another thing to consider for patients.
It's a great point. Endura is still available in Canada, but not in the US. It's a great vehicle. But there are, even Allergan's done some internal studies to show that bumping it up to 4 times a day, which is what I'll do for my severe dry eye or my Tigasins, 4 times a day has great success with your severe patients. So again, with our patient that presented today, the other thing we can think about trying in addition to adding medications is bumping her up to 4 times. And now she said she felt worse, but again, I'd really want to kind of delve into that a little bit more in detail.
No question from the audience. If you had anyone have any question, please you can put in the box. Regarding question to David, just about we had more dry eye here. Do you think the air condition is the main factor? And which is the draft or the humidity play more important role in that?
I'm sorry. If the decreased humidity of air conditioning or the
yes, is it the draft from the air condition or the humidity, which is you think is a play, or the temperature, which is a play more important part? Why we had more dry here in our environment?
That's a good question. So I usually don't think about. I think about high temperature being worse, just like the study about the sunlight duration. I usually don't think about cold being so more bad as opposed to the lack of humidity. For instance, in the United States during the winter, in places where there's a very dry winter. So I always think of much more about humidity, the humidity level, and thinking about places like my patients who live in the South, who live in places where it's very humid, they do better there than they do in places that are very arid. And certainly, I know a lot of people who, when they move to Saudi Arabia, have very bad dry eye problems they never experienced in the United States, where they lived in a more humid place. There's been excellent studies actually that have shown how a very dry air results in more rapid evaporation of the tears.
I think, Dr. Osama, it's funny that you mentioned that because I think you're right. I lived in Connecticut for 25 years, then moved to Florida, where it's like 95 degrees in the summer here, and it's completely different. And the point about the air conditioning, which I didn't even realize, is there's so many things that affect. David's right. Humidity affects it. When I was up in Connecticut, what affected the patients there was we would be doing LASIK in the midwinter, and the humidity would be like 19%, and these patients were feeling dry in the room, and so we couldn't do our LASIK. Down here, it's about the air conditioning, the draft and the wind blowing, right? So I tell patients now, we have a whole list of tricks to help our patients. Like when they're in the car, turn the vents away from their eyes because that wind can irritate the eye. The ceiling fans, turn them off. Lower the computer screen, right? When the computer screen's higher, you have more inferior scleral show. So all those things are great points. And I think, air conditioning, especially car air conditioning, is classic. It blows right in their face. And I realized it didn't dawn on me as much until I moved down here and I was, basking in the 95-degree heat.
About Dr. Mark, what do you think about the DREAM study about the omega-3? Any feedback?
Yeah, it's funny that I actually sat in on a discussion where we had a point-counterpoint with the investigators for the DREAM study and people who were looking at it from the opposite point of view. And if what the DREAM study did was they looked to see if omega-3s had any benefit, anti-inflammatory effects compared to a quote-unquote placebo. The problem is they used olive oil as the placebo. And so when they looked at those studies, their conclusion was there was no difference, meaning that omega-3s may not be anti-inflammatory. But if you delve into the study, what they realized is that the olive oil actually improved signs and symptoms of dry disease as well. So it's not that the omega-3s didn't work, it's that their placebo was quote unquote equal to the omega-3s, and the placebo was not truly a placebo. The definition of a placebo should be it has no effect. And so I think, in my opinion, my humble opinion, they just chose the wrong placebo. And so I think we all still believe that omega-3s do have anti-inflammatory effect, because even in that DREAM study, it showed an improvement of both signs and symptoms.
I agree with you, really. I think the good thing is that study show that we should use a lot of olive oil also.
Exactly. There is some truth to the Mediterranean diet helping, right?
Yeah.
So
a lot of olive.
Yeah.
No question, I'm afraid, from the audience. Seems to be everything very clear. I think it's thank you very much, both of you, Dr. David, Dr. Mark, and our patient. Thank Allergan for sponsoring this seminar, and thank you for the Emirati Society for organizing all this together. And it was a great day. And any final comment from both of you?
No, it was an honor being with both of you. I know both of you from my past, and so anytime I can get to see you both is great. So thank you, and be safe.
Yeah, so
Thank you
wonderful.
very much.
Thank you very much, everybody, all the organizers.
And thank you for the audience for staying too late with us today, and looking forward to meet them again on another activity. Okay, thank you very much, everyone.
Safe.
Thank you very much. Stay safe. Thank you. Bye-bye.